My name is Michelle Geyer. I am the Director of Emergency Health at the International Rescue Committee, or the IRC. The scale of humanitarian needs worldwide is at an all-time high and growing. But as a global community, we are unable to meet all the needs, even the basic needs of people, and this is particularly important and worrying for health. The IRC is stepping up to this challenge to improve the scale, the timeliness, and the effectiveness of our work to deliver health care to affected populations. We will do this with, as always, our international and national partners, and particularly working closely with communities. The emergency health strategy being discussed today lays out a path to achieve this ambition of more, better, and faster to improve the survival and dignity of crisis-affected populations around the world.
We'd like to request a few minutes of your time today to provide a brief introduction to the IRC's Emergency Health Strategic Plan. First and foremost, we want to emphasize that the Emergency Health Strategic Plan is not a standalone strategy, but rather an integral piece of the IRC's larger 2020 strategy and commitments for better aid. The IRC 2020 strategy has a strong focus on scaling up and improving emergency response. Of course, survival is the key imperative, the ultimate target outcome of emergency response. The emergency initiative under IRC 2020 has identified 3 priority program areas that the IRC believes will support survival most effectively, and in which the IRC therefore plans to focus its interventions during the initial acute emergency phase. These priority areas are health, environmental health, and cash. This is where the Emergency Health Strategic Plan comes in. The strategic plan essentially lays out a path to achieving key health and environmental health outcomes, which in turn strengthens the IRC's ability to support survival at critical moments of an emergency, and ultimately provide better overall aid to crisis-affected populations, as intended by the IRC 2020 strategy. Before diving in, a quick overview of what we will cover today. We'll begin with some background on what has gone into the development of this plan, followed by an outline of the vision for emergency health going forward. We'll touch on why the IRC is well positioned to deliver on this ambition, and finally, a look at the practicalities of what it will take to get there. As a first step, the newly formed Emergency Health Team conducted an intensive review of existing documents. Naturally, this included internal IRC documents, for example, the IRC 2020 strategy, and in particular, the Emergency Initiative and the Outcomes and Evidence Framework, whose evidence-based outcomes programming is a critical component of the IRC 2020 vision. A range of documents from partner organizations were also consulted, strategy statements from peer organizations, as well as important donor agencies, including OFTA and DFID. This review set up a landscape of the world of humanitarian health response, which served to highlight what is currently missing and suggest what might be needed to fill those gaps. We then took on a proactive consultation process, again turning to both internal and external sources for input. Specialists within all programmatic areas of health were primary contributors, but colleagues in the policy and practice areas of violence prevention and response, education, governance, and especially economic recovery and development fed in as well, as did colleagues from operational units. This is in recognition of the fact that robust operations capacity, in particular global supply chain, is essential to being able to deliver on our programmatic ambitions. External to the IRC, we consulted core global technical guidelines, including SPHERE, the MISP, and other IASC standards, as well as partners, mainly participants in the Global Health Cluster, and a number of key donors. Finally, and most importantly, country experiences were taken into account. A trip was made to Ethiopia to observe and consult with an IRC country program that has a range of ongoing health and environmental health programming and is also currently coping with acute health situations, including a cholera outbreak. This provided an important illustration of how the IRC's emergency work relates to its longer-term protracted programming. There have also been 2 emergency responses launched in the past few months, in Nigeria and in Libya, both responses leading with health programming. These experiences also provided important insights that molded the direction of the strategic plan. So what is the vision that we landed on for emergency health at the IRC? The vision is very similar, in fact identical, to the vision for emergencies. This because the Emergency Health Strategic Plan fits in with the broader ambitions for emergency response at the IRC, which are 1. To improve scale and reach, 2. To increase speed and timeliness, and 3. To be more effective. With regard to scale and reach, the IRC wants to be able to respond to at least 4 major emergencies simultaneously and reach a minimum of 10% of an affected population. The health component of the response, therefore, has exactly the same scale objective. Given the disparities that often arise in accessing health services, the Emergency Health Strategic Plan also makes explicit commitments to equity. While scale is critical, we must also ensure that we reach the most vulnerable, often most difficult to reach populations that may not have any other source of assistance. In terms of speed and timeliness, it is all about people and logistics, getting the right staff and quality medicines, equipment, and supplies to the point of response as quickly as possible. The target is startup of basic programming within 72 hours of the IRC's decision to respond. And for greater effectiveness, we will implement a signature set of high-impact, cost-effective, outcomes-based emergency health interventions geared towards systematically supporting survival. This will be called the Emergency Health Package, which we will come to shortly. Underpinning these objectives, you have the evidence and advocacy around which we will work. Whilst we're responding, trying to reach affected populations, to reach more of them more equitably, faster, and more effectively, we will also be working to gather evidence in order to guarantee that our programming is ever better. This goes hand in hand with advocacy. Quality program data and documented response experience will be used to determine new areas of research, to glean new best practices, and to advocate around critical issues, attacks on healthcare, for example, which currently impede our ability to reach people and respond effectively. The strategic plan has been built around a few basic but very important principles. First of all, the IRC has been an impactful health actor in various settings for many years, and the strategic plan plays to those existing strengths. The scope of the emergency health package are things that we already do and do very well. Now we will focus more on systematic integration. That is, we will ensure that health interventions in different programmatic areas, primary health care, nutrition, reproductive health, environmental health, among others, are coherent and coordinated and are linked to other essential emergency programming, such as cash and protection services. These linkages are outcomes-driven and informed by the organization's outcomes and evidence framework. Preparedness is another recurring theme throughout the strategic plan, and deliberately builds on work being done in IRC watchlist countries around emergency preparedness planning and country emergency teams. There's a strong emphasis on partnership as one of the main ways that we will be able to achieve the very ambitious goals that we've set out for ourselves, particularly with regard to expanding our scale and reach and improving the speed of our responses. As previously mentioned, research and innovation are key to effectiveness and inspiring the rest of the humanitarian community to follow suit. Opportunities for research and ideas for innovation therefore appear throughout the strategic plan. We've referenced the emergency health package a number of times now. So exactly what kinds of interventions does the package entail? The IRC will do emergency health programming in the following areas: child and newborn health, communicable disease, including outbreak surveillance and response, sexual and reproductive health, assessment and management of acute malnutrition and micronutrient deficiencies, environmental health, as well as continuity of care for non-communicable disease and mental health. For those interested, the full details of these interventions can be found in a technical annex. Now, to some this may sound like a long list of interventions, perhaps not all that different from what's happening in IRC health programs around the world. So then what's new about the Emergency Health Strategic Plan? Firstly, we will be trying to deliver all of these things systematically together, in a way that we haven't done before. Second is the focus on outcomes. One overarching outcome in particular, survival. It's not about implementing every single known intervention in all of these programmatic areas, but rather putting in place a limited but highly impactful selection of interventions that has been proven to save lives. Third, the interventions may employ a project design or approach that would never be used for programming in a protracted or development setting. The package therefore only includes interventions specifically adapted for emergency use. You'll also notice that the IRC has made strategic decisions to implement in certain programmatic areas at each of the different levels of care, community, primary, and hospital level, based on the coverage and survival impact that can be achieved. In summary, we've done many of these interventions before, but they've been done in different settings at different times. Now we'll focus on making sure that we're doing them systematically in a targeted, outcomes-focused package in order to achieve maximum coverage and greatest survival impact. In terms of approach, the first point to highlight is that emergency health response at the IRC will apply the same public health approach that has been used historically in IRC country programs. The second is that we will focus our interventions mainly at the level of primary healthcare. This combination allows us to achieve greater coverage and impact in key outcome areas. The third important point is that we will prioritize working through existing structures. In doing so, we aim to support, strengthen, and empower these structures for a more effective immediate response and to build resilience for the future. However, we will have mechanisms in place to be able to substitute service delivery in situations when certain populations cannot access existing systems. Generally, these are very vulnerable, marginalized populations, so instead of, or in addition to, working through existing structures, the IRC will deploy alternative models to ensure that we're equitable in our service delivery. This may take the form of mobile clinics, for example, or recruiting local staff to provide certain services. The vision for IRC emergency health response is based on the IRC's unique organizational capacities and the massive health needs currently unmet by collective humanitarian efforts. Particularly for health, few agencies are able to address needs at a significant scale. In addition to the challenges posed by shrinking humanitarian space in general, health programming requires a more skilled workforce than many other sectors in order to have the necessary diagnostic and treatment capacity. These healthcare workers and their facilities are also facing increasing targeted attacks. This means that fewer healthcare workers are willing to endanger their lives, facilities are damaged or destroyed, and many patients no longer feel safe seeking access. There are operational issues as well, especially related to maintaining consistent drug supplies. Underlying all of this is a chronic funding shortage. It is common for health to be funded to between 30% and 50% of what is actually needed, and this is decreasing. The IRC aims to confront these challenges and is well positioned to deliver on its approach for improved emergency health response. If you remember, maximizing coverage is a critical component of our approach. With the IRC working in more than 40 countries around the world, many of which have ongoing primary healthcare interventions and employ a public health approach, our ability to achieve this is already greatly strengthened. The IRC watchlist countries are also undertaking preparedness activities to be able to expand quickly or redirect existing coverage as needed. Then there is the fact that unlike most major humanitarian health actors, the IRC is multi-sectoral. As we all know, health outcomes are not just about health. Many other sectors contribute, and the IRC is unique in the sense that it implements emergency programming in all of them. And finally, we stay. We don't just work in an acute emergency and then leave. We have long experience in protracted emergency programming, local partner-focused initiatives, and community engagement. So what will it take to be able to provide better emergency health services to more people faster, as we envision in the Emergency Health Strategic Plan? There are 3 areas of strategic development here. The first is around technical capacity. This will require us to develop and advance our tools and guidance, to implement field-level training with country programs, support in-country preparedness activities, as well as push forward strategic research and piloting to make sure that we're using the best practices and approaches. The second is operational capacity, which is twofold. One aspect is supply chain, which involves increasing pre-positioned stock and strengthening supply chain, all the way from purchase to delivery at the point of service and beyond, including proper warehousing and consumption monitoring. The other aspect of operational capacity is enhancing our surge staffing in order to have staff ready to deploy quickly at a global level, but also at regional and country levels where we will have relevant partners in place. It is this local surge capacity that will allow us to reach people on the front lines of a crisis and expand the scale of our response rapidly. Hence, our plans to work intensively on strengthening partner capacity, both in technical and operational areas. All of this is really about preparedness, which will be the main focus of our work over the next 2 to 3 years. The final area of strategic development is around cross-sectoral engagement. We're not working in isolation. No one does, and we shouldn't. It's about collective results. So with this in mind, we will work closely with interagency fora. We will work with our partners from global to country level. We will contribute to the global quality of guidance, and will shape our programming using the evidence we generate and advocate that it be used to inform programming throughout the field of humanitarian health. If you recall from previous slides, we have set ourselves objectives of being able to respond to 4 simultaneous large-scale emergencies quickly and effectively. This will require organizational commitment and investment to get to this point. We will build capacity and investment incrementally, beginning with our current baseline, which consists of 8 core staff, 6 of whom are emergency response team field deployable coordinators, and about $250,000 in pre-positioned stock. We have mapped out the investment required to grow to minimum capacity, which covers 2 large simultaneous emergency responses, medium capacity, 3 large responses, and finally, full capacity, all 4 simultaneous large-scale responses. As you can see here, the investment to be able to respond at full capacity would be about $2.5 million annually. This estimate includes a much expanded emergency response team, supplemented by a range of other surge staffing mechanisms, a small core team of 6 at headquarters, training, and preparedness funds for about 10 watchlist countries and/or neighboring countries. The latter are funds that country programs can tap into to help with partner identification and training, localized pre-positioning, etc. Note that these figures do not include pre-positioned stock, which has been calculated as a separate one-off purchase that can then be replenished through grants during a response. When you step back and think about it, $2.5 million per year is not actually a heavy price to pay to be able to reach 10% of the affected populations in 4 large-scale emergencies. As we've said, this is not going to happen overnight, and it certainly doesn't mean that we can't respond to emergencies right now. Of course we're responding to emergencies. But over the next 4 to 5 years, we need to build up our capacity to a point where we're able to respond as we envision, reaching more people, more equitably, faster, and with greater effectiveness. This is what it will take to get there. Now that we've defined our vision for emergency health and identified the path we think will get us there, it's time to operationalize. Immediate next steps will be to update core emergency health response tools, notably sector toolkits for emergency programs, or STEP, in health, and assessment materials and methodologies. As we've emphasized throughout, internal and external collaboration will be essential to the successful implementation of the strategic plan. So in coming months, we will re-engage programmatic and operations colleagues to ensure concrete and progressive steps are being taken, and we'll look to establish new relationships or strengthen existing relationships with partners to help us achieve the technical and operational capacities we've outlined here. Over the next 5 years, we will also need to do some critical recruitment, mobilize resources, and of course, continue to respond, as we're already doing in Libya, Nigeria, and other countries. We will monitor and evaluate how we're doing along the way and make any necessary course corrections. This is to be done not only within the IRC, but working closely with our partners globally. In conclusion, the aim of the Emergency Health Strategic Plan is ultimately to help achieve what we've already set out to do with the IRC 2020 strategy, its vision for better aid, and within that, its emergency focus. The contribution of the Emergency Health Strategic Plan is the delivery of key health outcomes that will support the survival and dignity of crisis-affected populations around the world.